Good morning, all. So I'm Adrian Gardner from Birmingham, and I'll start again. Hello, I'm Adrian Gardner from Birmingham. I'm here with my partner in crime, Jonathan Lucas, to moderate the session on growing spine. And I'm pleased to welcome Colin Nardi and Neil Davidson, who are going to talk about the magic rod, and Thanos Sirikos and Vinay Jasani, who will cover the ins and outs of VBT. The plan is to run all of the talks back to back, so we'll have all four talks. Please put any questions you have into the chat function that Jonathan and I will moderate, and speakers can answer as we go along if that's useful, and then we'll deal with any questions at the end, time permitting. So Henry, if you'd like to play the talks, I'd be very grateful. Thank you.
Good morning, ladies and gentlemen. My name is Colin Nardi, and I'm a consultant spine surgeon from Oxford. I'm going to talk to you about the clinical evidence for magnetically controlled growth rods. These are my disclosures. When the rods first came out, they were supposed to make life easier for children with early onset scoliosis. They were described as a game changer. And so what I'm going to do is look at the evidence, see how it's fared, has it provided benefit, and has it actually reduced the burden of surgery. The inception of the rods was all based on the historically reported high complication rates with the traditional technique. It was first developed in 2007, first used in Hong Kong and the UK in 2009, but it would be 5 years before it was recognized in the UK. The basis of this was the economic template provided by Rolton et al., which showed cost savings of just over £12,000 per patient when compared to the traditional methods. Similar results were found for the UK healthcare, the US healthcare system. So lots of reports then started to surface about the device, but they all had one thing in common, that there was spinal deformity control and promotion of growth when it was used. Some authors even reported on improvement in pulmonary function. Our series showed that the device provided a stable correction of the curve in both primary and revision cases. In terms of design, it's undergone 7 design alterations since initial production, first and second generations being pre-2015, third generation in 2017, and more recently, Generation X. As with any evolutionary changes, problems do arise, and there have been 3 field safety notices to date. First in 2014, due to rod fracture, the second in 2019 due to actuator pin failure, and more recently, NCAP component displacement. It was really in 2017 that some of the problems we thought were a thing of the past began to resurface. Unplanned returns to theatre rates of up to 50% were discovered, and then tissue metallosis was also first reported. In a small study that we did, we found no device failures at 2 years and also felt it was safe to use, but complication rates were still high. And in a larger series, we found patients with dual rod constructs, idiopathic etiology, and primary surgery after age 7 were more likely to do well. The overall complication rate still remained high. Most complications occurred at 3 years, and we therefore proposed exchange or conversion to definitive fusion around the 3-year mark. The Liverpool group also reported on good results. Problems of PJK, loss of distraction continued to hog the headlines. We looked at distraction ratios and showed that for every unit of distraction registered on the remote controller, only a third of true distraction actually occurred. We also showed that the law of diminishing returns still persisted in the new device. In terms of distraction itself, whether to do incremental distraction or continuous distraction to stall remains controversial. We've recently come up with a smartphone application technique to try and improve this, but further studies are needed. Quality of life measures has been looked at, and it has fared favorably with the traditional methods. We've also just recently submitted a review article, which is shortly to be published, and we feel that despite the complications, it still offers one of the best solutions for treatment of this condition. So in summary, it has revolutionized treatment of early onset scoliosis in my view. It remains the device of its generation. Patient selection is key, but it hasn't solved the complexity of early onset scoliosis treatment, but it has made significant inroads into the problem of repetitive general anesthesia. And with that, I'd like to thank you for your time.
Good morning. My name's Neil Davidson. I'm a consultant orthopaedic spinal surgeon based at Robert Jones Agnes Hunt Hospital, as well as Alder Hey Children's Hospital. My task is to take you through the complications associated with magnetic growing rods in the next 5 minutes. This is an overview of the literature along with my own experience. This table shows complications related to magnetic growing rods. They're not uncommon. Many people have shown that early and medium-term data with unplanned operation rates ranging anywhere between 33 and 46%. The table here highlights complications in yellow, which are equivalent to other surgical options. The green areas symbolize reported advantage of MAGIC over other options, and the red indicates specific modes of failure which are related specifically to the rod itself. Similar to traditional growing rods, magnetic growing rods have a high rate of implant-related complications like rod fracture, shown here, and anchor failure, also shown here. There is evidence of reduced rates of infection within this population group. The most common causes of reoperation in MAGIC are failure of rod distraction and failure of proximal foundation. There is a rate of failure to distract within traditional growing rod group. This is a result of autofusion and is also indicated on the chart. But the nature of the mechanism of the MAGIC brings a specific list of possible causes of failure to distract: pin breakage, tissue interposition, and force decline over time. The second and very specific complication related to the mechanism is also the generation of metallosis around the actuator. So failure to distract. Avoidable and mechanical. Bending the rod incorrectly in theatre can damage the actuator, resulting in mechanical failure. Incorrect placement or orientation of the rods can result in an inability for the external remote control, the ERC, to talk to the rods. Mechanical failure like pin fracture, which we can talk about later. Tissue interposition with bony growth in the actuator can prevent extension. And if you implant these rods into kids with an significant adipose layer, it can reduce the ability for the ERC to talk to the actuator and generate force. The law of diminishing returns has been demonstrated to be more gradual than in traditional growing rods, but it is there. It's related to time that the implant is in the patient, and also there are bench studies which suggest that the longer the rod is extended, the less force it is able to generate. So on to pin failure. The design change in 2015 has demonstrated some improvements in the rod in the pin fracture rate from retrieval studies in the UK. You can see this clearly demonstrated in the data that's provided. The image you see here is of a retrieval study X-ray showing the nature of the failure, and also a macroscopic image of what we find. Retrieval studies are useful because they show the mechanism of failure and also identify possible patients and surgical factors. But it doesn't give a clear indication as to the actual rates because the denominator are of explanted rods and failed rods. Specifically to do with metallosis, end cap separation or failed O-ring, which are both the seals within the actuator, and therefore if they fail, they expose the patient to the internal workings of the mechanism. You can see here a close-up of the end cap separation seen on a recent radiograph. So metallosis is the granular particle accumulation within hyalinized fibrous tissue, which you can see on the video here. The metallosis is contained within that sleeve. And the significance of the debris and long-term effects are currently unknown. But you'll see in the chart on the right-hand side that titanium and aluminium are present in the serum in both traditional and magnetic groin rod patients, but vanadium is specifically found in the magnetic group. Compounds found within the magnet have yet to be identified within the serum. Our 4-year, 44 patient follow-up data gave us 3 patients requiring revision surgery because of actuator failure. These are a difficult population to treat. Magnet is not the perfect solution we were hoping for, but it is one of the better ones in my opinion. We need better data collection and standardization of technique with more information about the metallosis for future patients. Thank you.
Good morning. I'd like to share with you a few thoughts about vertebral body tethering. I have no disclosure. So the concept of VBT is based on the thinking of modulating anterior vertebral growth in order to correct the scoliotic deformity using the Hütte-Volkmann law by applying compressive forces that can inhibit growth on the convex side of the deformity and allow for the concave side to catch up and correct the curve, in the same way as we can correct a limb angular deformity or a leg discrepancy. And the whole point is to preserve growth, especially in the lower spine. The concept is based on the use of tethers. That was the initial device that can create a curve in animal models. The technique involves the use of anterior transvertebral screws with set screws made of titanium alloy and a tether which is made of polyethylene. Compressive forces are applied on the convexity. The technique is meant to be minimally invasive and primarily thoracoscopic. However, there are issues with the screws that can be prominent, can migrate or pull out. They can be technically difficult at distal or proximal levels above T5 and below L4, and the trajectory can be challenging. The tether is meant to be placed in an area where there is movement so it can fail and require revision. And it is still unclear how many vertebrae have to be included and how much tensioning has to be applied. In addition, what happens if the tether breaks? Does that always require revision? How can we avoid or reduce intraoperative complications? And what happens at the end of spinal growth, where either the tether will fail or the spine will be spontaneously fused? These are a few examples. Patient 1 is a good control of a thoracic curve. However, you can see that thoracic kyphosis has not been restored. In patient 2, there is evidence of a break of the tether with some loss of correction over time. These are Lenke 3 curves. The patient 3 and patient 5, only the thoracic curves were tethered and the deformity was stabilized. However, both patients are now braced to control the lumbar deformity. The middle patient, patient 4, had a major hemorrhage during the attempt to perform tethering of the lumbar curve, which was abandoned. So there's a whole lot of recorded complications with the use of this technique from intraoperative to postoperative, including failure of the implants, loss of correction or overcorrection, and injury to great vessels, the heart, the lungs, and uncontrolled bleeding. The complication rate varies from 28.1% in a recent Canadian study, multi-center study, to 86% in the original FDA study. And there is a need for the operation, which varies from 14 to 47%. So the FDA has suggested that there's a probable benefit for primarily thoracic, but some thoracolumbar and lumbar curves that are flexible, that there is not much rotation, and there is less than 40 degrees of kyphosis in patients who are not that immature. However, there are still questions in terms of the long-term outcomes in terms of what is the reoperation rate, what is the risk of spontaneous fusion, what are the patient outcomes, what does compression do to the discs, what is the retained mobility of the spine, and what could be the effects on pulmonary function. And I think in terms of take-home thoughts, the indications for this technique are primarily for thoracic curves that are small in size and the patients are not too young. However, you have to remember that for thoracic scoliosis, a thoracic posterior spinal fusion can achieve a good result, and it's a one-off procedure, fairly predictable. Ideally, we would like this technique to work for early onset scoliosis, which has not been proven to work, and for thoracolumbar or lumbar curves, where again, the results are not that satisfactory. It is proclaimed as a low risk procedure, but that is certainly not the case, as it has not demonstrated reasonable safety. Remember that scoliosis is a not life-threatening procedure, so the ways to correct it should be safe and reproducible. There is insufficient evidence, and there is certainly a need for future studies. Designated centers and prospective design is what is required, and good documentation of complications and patient-reported outcomes through registries would be extremely helpful to validate the technique. Thank you very much for your attention.
Good morning, everybody. My name is Vinay Jasani, and I've just got a short presentation on VBT, particularly focusing on the expectations and outcomes from a UK perspective. So just touching a little bit on evidence. So evidence to date, so there's been more publications since the FDA approval, so we've got a mean follow-up of 48 months. You could argue not all complications have been published on, but those that have seem to suggest a reasonable safety profile. Complication rates vary anything up to 38%, depending on what you define as a complication. Take-home messages from the literature. So if the kid's too immature, then you're more likely to get into overcorrection problems. And also there does seem to be a slight loss of the cob correction with time and longer term follow-up. So a couple of comparative studies, one which compared fusion versus VBT and found that fusion was better at maintaining cob correction, and another which looked at PROMS data and found that there was no difference. So to date, we don't have any superiority of VBT over fusion. We performed a survey on a UK VBT support group, which is a patient group which has undergone awaiting procedures around tether. So patients have either had VBT or ASC, ASC being a tether in a skeletally mature patient. So we asked the question why they're going for these procedures and wanting to avoid fusion, and the majority felt it was to try and avoid stiffness, and also to try and reduce the current pain they had and prevent pain long term. So we flipped that question on its head and asked, well, why were you going for VBT? And the majority wanted, the main expectation that they had from VBT was to maintain their flexibility. Drilling down a little bit more, so detail in terms of activities that patients were doing preoperatively. So this is the range of activities they presented. And then we asked if they maintained those activities post-operatively, and you can see that the majority did. So 85% felt that they still maintained activities to an extent, although 11% had stopped activities specifically because of surgery. So things that perhaps we look at a bit more, so trunk shape. So interesting enough that not all patients were happy with trunk shape, and 20% were unhappy with the trunk shape or more negative about it. And in terms of the scars, again, almost 25% were unhappy with the scars. But when we asked them specifically if they were happy with the expectations, did their expectations get met? So the reason they went for VBT was that met. It was overwhelmingly met for both tether procedures. We did a survey of the BSS members. Unfortunately, the response rate wasn't as good, but I'm going to just present that data to you. So again, the question, why as a healthcare professional group do we think VBT should be done? And the main reason was around flexibility and growth modulation for VBT and flexibility for ASC. The purple column there are whichever responders put down that they do not feel that there is any indication for either, so a positive no. We asked for reasons against VBT or ASC, so why shouldn't we be doing it? And I thought it was going to be lack of evidence, but actually for VBT, the majority concern was around the rate of complications. And again, you can see a range of other answers there. So in terms of which patients we do VBT in, so the majority felt it should only be on idiopathic scoliosis and skeletally immature idiopathic scoliosis. From a cob angle perspective, it was felt appropriate for the 40 to 50 degree range. And when we asked whether brace should be trialed first before VBT, and the majority, so almost 70%, felt yes, so brace first, and only if that fails would we go for VBT. And again, you can see throughout each pie chart, there's a group which just would not offer their surgery. So when we directly asked that question, would you offer VBT if it was commissioned and available? Then actually, majority probably said yes for VBT, but there was a group of almost 20% who were more negative and would not offer VBT. And for ASC, that proportion changed significantly, and there was a large group, almost 40%, who would not offer ASC if it was available. I'm just going to touch back on the complication rate, because remember, this is something that plays on our mind as a healthcare professional group. And actually the complication rate, when you look at self-reported complications in the UK group, is around 60%. So if you take out broken tethers and pleural effusions and things which are felt to be almost part of the procedure, then it drops to 19%, but still significant, I'd say. And then 19% have a reoperation rate, majority of which were due to tether-related problems. So thank you very much for listening. I'm sorry about the death by pie chart type presentation, but I thought it was the best way to present this survey. I'm happy to answer questions later. Thank you.
So thank you very much for all the speakers for some excellent presentations. Questions that we've had in the chat. Mike Hutton has asked, given the report on medical devices, how does the panel feel that these and other spinal innovative technologies should be introduced to the UK market?
Do you want me to take that question?
Yeah, anybody can.
Okay, so I think it's a really good question, and Mike may have talked about this before. So I think VBT in particular, but any other device should go through the appropriate sort of multi-center feasibility studies, etc., and ideally overseen by the appropriate societies and NHS England. But I think the biggest thing is that they should go to this ODEP Beyond Compliance program. So I think any implant, you could argue even any change in an implant, for example, if you change the rod shape and rod diameter, you could even argue that should go through ODEP, because you can get rod breakages, etc. So that's the philosophy I would take.
I suppose putting that to the MAGIC group as well, it's a slightly different question, but how do we resolve the current MAGIC issue that we have in the UK, one way or the other?
Neil, do you want to go first, or do you?
Yeah, okay, yeah. I mean, I think registry is the key, isn't it? And collection of data, not just the type of rod that's put in, but which patients, what your protocol is for lengthening, your construct top and bottom. So there's so many factors that play into it and the process, but it's certainly something which needs closer regulation. I think that's probably going to be coming in anyway, but I think it's our duty really to make sure we put all of this data and make it available.
Yeah, no, I would support that, and I think our surgeons, we also need to take a closer look at ourselves about our patient selection criteria and surgical technique. We've always said, about the way the rods are placed, the type of curves they're placed in. Patients who are hyperkyphotic, perhaps the MAGIC isn't the best device for them. So there are all these things, and then following up the data, following up our results as well to see what is actually going on, and then an acceptance that MAGIC or the magnetic growing rods are not the panacea for early onset scoliosis. It's one of several options.
Okay, question from Ashley. Vinay, can you give us any details about the planned NIHR study, inclusion criteria and primary outcome?
Yeah, so the inclusion criteria have been built. I've kind of presented them before in previous BSS presentations. So the inclusion criteria are built on the evidence that is available, which I accept is not great, and based on some surveys like this, and also in terms of what patients want to define the primary outcome. So currently, inclusion criteria that we're building for the NIHR proposal is going to be adolescent idiopathics only, skeletally immature, and patients who have had brace treatment and failed. So either they're too late for brace or they have had brace treatment and failed. So that's going to be the main inclusion criteria. We've gone into the thoracic kyphosis as well, because that was a thing with the early VBT publications, was that if they're too kyphotic, we shouldn't go ahead with those. So we put that in as an exclusion criteria, and the non-idiopathic, etc. exclusion. In terms of the primary outcome, so I've used what the patients want as to try and define that. And it seems there's 2 surveys I've done now, one 2 years ago and one currently. And it just seems flexibility is the main thing that people are wanting. And it seems, again, from the BSS survey, it's the same aim, isn't it? Is to maintain flexibility and its potential advantages. That's how we're going to look at the primary outcome. The difficulty is measuring that with one outcome measure, which is what I'm working on now.
Thank you. So, question from Chris Adams, comment about MRHA exemptions, and then a question: what is the rate of current UK MAGIC versus non-MAGIC insertion? And I'm assuming he's thinking that since we've had the MHRA ruling on not putting them in as a routine, are people still putting in MAGIC, or has everyone gone back to traditional other older systems?
I mean, I don't know anyone who would have the data to tell you the rate at which they're going in. Certainly, there are limited criteria for it currently through the NHR, and there is a panel that's meant to be assessing each and every case. For us up in Liverpool, we've stuck to the rules, and we're just putting in MAGIC to MAGIC conversions, so patients who've already started the treatment and require an exchange of rod. And for the others, we're going back to traditional rods until the outcome of the NHR discussion is complete.
Fair enough. Question from Jonathan, and I suppose this is for MAGIC, but I suppose could be in some ways applied for VBT too, and it's metallosis. Should we be worried about it?
I can say, I mean, that was in my presentation. Certainly the studies done is around serum and collection of the debris. So titanium and aluminium present in traditional growing rods found in serum. Same for the magnet. The specific alloys and metals in the magnet, like vanadium, have been found in the serum. The long-term impact of that is not known. It is an issue and it is a concern, but it needs longer study. Of course, vanadium and things like boron and neodymium, they have yet to be found, but again, long-term impact unknown. But I think that's something that really needs to be looked at more closely.
Yeah. So I'm going to use moderator privilege, and I mean, Mike Gibson and the Newcastle group have been quite vociferous about this and say we're doing something that we don't know the outcome of for something that may be quite important, and that perhaps we're sweeping this under the carpet. Do you think we are justified doing it when we don't know the relevance of metallosis? And I speak as someone who has used and is using MAGIC. Colin, do you have an answer to that? Because we've only got 30 seconds left, I think.
Well, I think it's the registry data. We've got to monitor what we're putting in and monitor our outcomes. I don't think there's any other way around it. And I don't have an answer. When it's used appropriately, you get very good results. But whether that justifies the risk with metallosis, I don't know, Jonathan.
Okay. Last question then from Rajat to both Vinay and Thanos. What do you currently quote as your complication for fusion surgery, and is it less than 19%?
Yes, it's less than 19%, clearly, yeah.
And I'm assuming that's based on noting the 19% complication rate for VBT and weighing the two together.
Yeah, I think the sad thing is that the publications, the evidence doesn't really report on the complications, so that needs to be addressed. But yeah, I for fusion surgery, I quote less than 19%.
Okay. I've just put through the last couple of questions. We're going to be out of time. This is obviously going to trigger some debate, which I think can probably carry on out of this forum, but we are going to have to move on to the next session. So thank you very much for all the speakers and all the questions.
Thank you. They were fantastic talks, so thank you very much.
Thank you.